Hello,
Yes, sir. Good evening.
Mr. Uncle.
Yes, sir. Good evening, sir. How are you, sir?
We are live on audio.
Hello.
Yes, sir. Audible, sir.
At the same level, yes.
I'm audible, sir?
ओंकार जी
हाँ, audible हूँ मैं, sir.
Yes, yes. Yes. We are live.
Mr. Uncle, are you there?
Yes, sir. I'm there, sir.
Am I audible?
I'm audible, sir. Hello.
बट समाव लगता है डॉक्टर लिंगराज को हम लोग का साउंड नहीं जा रहा है।
हाँ, मेरा आवाज आ रहा है राजकुमार सर आपको?
हाँ, हमको आ रहा है।
I think लिंगराज सर हेडफोन यूज कर रहे हैं क्या? नहीं।
Just call him and inform that he has
एक बार
probably has
ओंकार जी
joined
आप
without
फोन कीजिए ना उनको।
हाँ।
Hello.
Yes, sir.
Hello, लिंगराज sir.
Let me switch to my another, but I'm unable to hear.
Okay.
Hello.
Yes, sir. Audible, sir.
Yeah, now I can hear.
Okay, sir. Okay, sir.
So, good evening, everybody.
So we can start, sir. So just on behalf of Alchem, I will welcome you all. So good evening to all, sir. On behalf of Alchem, India's fifth largest pharmaceutical company, I welcome all our eminent moderator, panelists, and all the doctors who have joined us for this today's anti-thrombotic debate. Doctor, at Alchem, it has always been our endeavor to partner with healthcare professionals, and we continue to do so. And to help us navigate through the meeting, we have with us a renowned cardiologist, Dr. Lingraj Nath, who will be our moderator for today's debate. So I welcome Dr. Lingraj Nath, and we also take this opportunity to welcome our eminent panelist for today's program, Dr. Subhasis Mishra, Dr. Pradeep Kumar Das, Dr. Suryakant Jena, and Dr. Priyabata Sahu. So with this, I would request Dr. Lingraj to initiate the program proceeding. Over to you, sir.
Yeah. Hi. Good evening, everybody. Mr. Uncle,
Yes, sir.
how is the COVID situation in Mumbai?
It is slightly improving, sir. Last couple of days, but we have a storm over here on with heavy rains.
So you are not selling Remdesivir?
No, sir. No, sir. We are happy with Deviclot as of now.
Deviclot, but people are minting millions of rupees with
Yeah, that is true, sir.
chloroquine and remdesivir.
But nowadays, some other trials are coming up. There is no need of remdesivir, no need of HCQS. I don't know what to believe or not to believe.
Yeah,
So-
absolutely. That's true. Okay, so good evening, all my panelists and friends. So I guess we have a academic program today. Topic is my voice is echoing or it is fine?
It is clear. It is fine, sir.
Okay, somehow let me switch off my laptop. There is a double thing it is coming. Okay, so today's topic is very relevant and very important topic, and it is about two most important situations where we are using the hello.
It is echoing now, sir.
Yeah. Let me see just one. Hello.
Yeah, now okay, sir.
Yeah. So we have two topics today. Both are related to anticoagulation and antiplatelet. First topic is, I guess, management of ACS with newer antiplatelet agent, Mr. Omkar, or
Yes,
the
sir.
other one?
Yes, sir. Yes, sir. ACS, first one, antiplatelet.
Okay. So the first topic, you are going to have a case presentation first.
Shall I present the case, sir, if you don't mind?
Yeah. You go. Yeah. First, you will have the case presentation, and
Yes.
then we will have a panel introduction and discussion.
Thank you, sir.
Thank you.
So I'll present the case. The first case says that there is a 72-year-old male who comes into emergency department complaining of sudden onset of chest pain since 1 hour. The pain was typical of cardiac origin, and the person was smoker, non-diabetic, with history of hypertension. ECG shows extensive inferior wall MI. BP readings are 130 by 70 millimeter of mercury with a pulse of 70 beats per minute, which is regular. And the patient is ready for intervention. And as you can see the ECG of the patient on the screen over here. So with this, these are the probable treatment options where all the panelists can debate upon which treatment option would be suitable to manage the particular case of the patient. And before this, may I request Rajkumar sir to briefly introduce the panelists once again, if you don't mind, Rajkumar sir.
Yeah. So we have Dr. Pradeep Kumar Das, who is a DM cardiologist, and Dr. Sibasis Misra as a panelist for this case study.
So let me start with this case. Should I, sir? Lingraj sir, should I start?
Yeah. Yes. Please go ahead. Yes.
So the thing is that we have a case which is 72 years, and I think there is no comorbidity. It has not been mentioned, and the ECG is showing a very acute, maybe hyperacute inferior MI. So this is one thing. With 72 years and a proper window period with a ST elevation in 2-3 AVF, this might be a case for proper intervention. So primary PCI is a viable option for this patient. And I think if the patient is suitable for revascularization, and as already told, that patient is ready for an intervention, then the choice of agent, I think practically aspirin with ticagrelor 180 mg. We have to assess the bleeding risk, whether the history, the proper bleeding risk has to be ascertained, because one of the thing I have in my mind is that patient is in a later age of elderly population. I think the elderly definition is not been assigned in a trial. Some trial has included elderly population as more than 75. Even some trial has it started with a 65 of years. So I think this patient is in a later age of 72 years, but we have a confusing report right now at present, what has been not there from the plateau trial. In the plateau sub-study of the elderly population, they have clearly says that it is suitable for any group of age. So any group of age means that is more than 75, even it is suitable for a later age over the 80 years of the age. There is a slight increase in the bleeding risk, but the major adverse cardiovascular event is almost similar to that of less than 75 years age. If the patient is suitable for a revascularization, I think the better choice will be aspirin plus ticagrelor. Coming to the bleeding risk only, you have to assess the bleeding risk of this patient. If the patient is not a suitable candidate for revascularization, it is not this case. It is not actually the patient is a suitable case for revascularization. Had it not been the suitable case for revascularization, then I might opt for a aspirin with a clopidogrel. That is not a bad option for the 72 years of the age. Obviously, if the patient is going for a revascularization, then we can give aspirin with ticagrelor. That is a very suitable option, provided there should not be any bleeding risk. So should be a debate on the patient with a elderly population. Patient with elderly population, what should be the suitable antiplatelet therapy in the elderly population? Because right now it is in a confusing era, in a dilemma actually. What should be the choice? The ticagrelor should be the choice in elderly population or not? If the plateau study has been published some 10 years back, and 8 years back, the sub-study has been published about the elderly population. Now, if you see the Swedish Heart Registry that has been published just recently in 2020 in circulation, if you go through that Swedish Heart Registry, it is have a confusing conclusion. It is showing that ticagrelor is not an effective drug for elderly population over 80 years of the age. That is a registry, that is not a trial. So not a dedicated trial. But if we are only concerned about this case is a 72 years with a very acute, hyperacute ST elevation. Patient is a suitable candidate for revascularization. That is, patient does not have any bleeding risk. Then aspirin and ticagrelor should be the choice. That is my opinion. Over to you, sir.
Yeah, that Dr. Sibasis, and this looks like a good idea. Actually, from the history, we can only gather some basic information about the patient, that there are many other important factors which is also helps us in taking decision in such a situation. One will be, of course, the renal status of the patient. And other thing is the body weight and any previous history of stroke, because whenever we are doing anticoagulation, these issues are also very important. Traditionally, we have always used ecospirin and clopidogrel for a very long time. Initially, clopidogrel was loading up 150, then it became 300, then now 600 has become standard by most of the people for this thing. The disadvantage of clopidogrel had been the suboptimal anticoagulation, antiplatelet activity, because of several factors that like polymorphism and bioavailability varying from person to person, leading to which the what you can say as antiplatelet activity suboptimal compared to new generation of molecules like prasugrel and ticagrelor. Up to 2% of the patients on clopidogrel and ecospirin going for intervention can have subacute stent thrombosis, which is from the interventionist perspective, is a very most dreaded situation. So this 2% is a very large number. That is why they have been always trying for a better molecule which can give us a better antiplatelet activity while maintaining less bleeding risk.
Yes.
So in this context, Prasugrel and Ticagrelor, those were started and now have become standard of use for most of the institutions going for intervention. So in this case, like I agree with Dr. Sevasius that age for 72 years is not a contraindication for the patient. And Ticagrelor can eminently be given for this patient as a loading dose of 180 milligram, that is with aspirin for doing an intervention. I'd like to ask our other panelist, Dr. Pradeep. Pradeep Das, is
Yes.
he there?
Yeah, sir, I'm there.
Yeah, Dr. Pradeep. He has
Yeah,
been
yes.
our resident in Amri Hospital earlier. So,
Yes.
welcome, Dr. Pradeep.
Thank you, sir.
So, tell us what you feel about the case, introduction of the case, and what would be your approach in such a situation. Then we'll go to some other discussion on the topic.
Yes, sir. Sir, it is very much clear from the European Society of Cardiology guidelines that any patient who is having a STEMI and acute coronary syndrome, Ticagrelor and Prasugrel will be the first choice. And while loading the patient, generally we do not see the bleeding risk. The bleeding risk comes when you give these drugs for prolonged period of time, like 6 months or 1 year. So I think in this case, if you are going for angioplasty, Ticagrelor would be a good option. And regarding, because the choice of antiplatelets depend under circumstances, whether you are going for an invasive procedure or a non-invasive procedure like fibrinolysis, or you are simply going for a medical management. I think medical management, my other co-panelists told that Clopidogrel will be a good choice, but still I prefer Ticagrelor will be a good choice even if the patient goes for a medical management. And regarding, we can go for Prasugrel as well. And Prasugrel, the relative contraindication being if the patient is not having an active pathological bleeding, or if the age is more than 75 years or the weight is less than 60 kg, and the patient is not having any prior history of stroke or TIA. Then in that case, Prasugrel may be another choice. But in this scenario, I think Ticagrelor will be a good choice. But for that, we need to know the angiogram, whether the patient is having a single vessel disease or a multi-vessel disease, whether we are going for a complex angioplasty or we are going for a simple focal lesion angioplasty. So I think angiogram will, but nowadays, Prasugrel, unless and until you know the anatomy, Prasugrel is generally not given. So you are left with whether you want to load with Clopidogrel or you want to load with Ticagrelor. And Ticagrelor, all these studies have shown that it is a potent antiplatelet. It achieves the antiplatelet activity within 30 minutes of administration. And in renal as well as in hepatic impairment, it doesn't require that amount of dose modification. So I think for me, Ticagrelor, I will go up with Ticagrelor 108 milligram loading dose. Then regarding the continuation of the drug, whether we can continue it for a dual antiplatelet for 3 months, 6 months, or 1 year, then we can debate on that. But loading dose should be, I think for me, it should be 180 milligram of Ticagrelor with aspirin 325 milligram.
Yeah, Dr. Pradeep, that's a correct thing. And regarding loading, actually, most of the hospitals, when the patient will give the loading dose right at the emergency. So we cannot wait for the angiographic report to be seeing and then start with either with Prasugrel or with Clopidogrel. I mean, Ticagrelor.
Yes.
Even though in many trial settings they have done that, so that they can, because as a trial only they have done after angiogram to starting different antiplatelet agents. But if you see any standard clinical practice like we have, most of the time the patient will get in the emergency only either Ticagrelor or Prasugrel or Clopidogrel. So even many times patient get it from the outside also. So that is fine. We expect that most of the patient nowadays, at least in the interventional setting like ours, come with a dose of ticagrelor and aspirin because of the advantage of ticagrelor of having shorter duration of action and more efficient and clear-cut antiplatelet activity. So the other important aspect regarding ticagrelor, I mean DAPT regimen, ecosprin as well as any other antiplatelet regimen, is for how long we have to give. What is the duration of the dual antiplatelet regimen? So whether it is 1 month or 3 months or 1 year or like newer DAPT trials, which has extended use of the antiplatelet, dual antiplatelet ticagrelor for even longer period. So I would let's have opinion. Dr. Sibasis can start.
Yes.
Regarding this.
Yes.
What is the minimum duration and what is the maximum duration of DAPT?
Yes. Sir, duration depends. This is now a very interesting area actually. What should be the duration of the therapy, dual antiplatelet therapy, and there are many school of thought actually. The newer generation drug-eluting stents, what is the trial has been shown that you can go for a shorter duration of dual antiplatelet therapy. The standard protocol is 1 year of dual antiplatelet therapy. But there should be a trade-off between the ischemic risk and the bleeding risk of the patient. What should be the anatomy of the patient, anatomy of the coronary revascularization? If I'll say, for example, if there is a left main, the proximal LAD, the ostial LAD, there is a bifurcation lesion, you are going for a CTO for a different case, then I think there is a much more chances for stent thrombosis and there is a greater chances of ischemic event. In that case, we can go for a longer period of dual antiplatelet therapy. So the duration of dual antiplatelet therapy is always a balance between the ischemic event and the bleeding risk. Suppose a patient has a CKD stage 5, and there is a higher chances of bleeding risk. There is a fertility patient, the patient has a lean body weight, there is a higher chances of bleeding. We have implanted a newer generation drug-eluting stent. And we have a type A lesion, stented a type A lesion, revascularization a type A lesion, then the duration can be shorter duration, can be up to a 6 months period. Even 3 months is also advocated in some trial. So in that case, we have to balance between the ischemic events and the bleeding risk. So there are scores, the DAPT score. The DAPT score has advocated for that case in which patient will advised for a longer duration of the dual antiplatelet therapy. And if I will say our scenario, like Indian subcontinent, what we feel that there is a chances for very late stent thrombosis also. In our scenario, the anatomy, we are not finding a very type A lesion. We have a genetic predisposition, we have a diffuse lung diseases, we have a much more higher risk for a non-culprit artery thrombosis or non-culprit artery reinfarction rate in our Indian scenario. So if the patient is suitable candidate, patient is having a lesser chances of bleeding risk, then we can go for a longer duration, even 3 years period of dual antiplatelet therapy, if there is no contraindication for going for a dual antiplatelet therapy. If there is no bleeding risk, if there is patient is tolerating the dual antiplatelet therapy, it is only the chances that two things. You have to relieve the very late stent thrombosis, minimize the risk of very late stent thrombosis. Second is to minimize the risk of non-culprit artery reinfarction. That is the one chances. The most of the reinfarction is due to the non-culprit artery lesion. It is not due to the culprit artery lesion. So you have to, because we have epidemiology different from the Eastern population. The Indian patient, if he is tolerating the dual antiplatelet therapy, so it should be advocated for a longer duration, even 3 months. In our clinical practice, we have seen so many patients on dual antiplatelet therapy for longer duration. Still, patient is tolerating well. So it is always a balance between the ischemic event and the bleeding risk of the patient. So that is always a trade-off between your ischemic risk and the bleeding risk. That is should be the answer, I think. Sir. Over to you, sir.
Yeah, very good point. Fair point. All patients are different. We cannot club each and every patient similarly. Like one patient who needs emergency surgery after 6 months of stenting, he is different. Another patient who has multivessel stenting with a history of significant chances of any procoagulant events, he is different. So, like Pegasus trial extended the use of antiplatelet, dual antiplatelet up to 36 months, even longer also. So the minimum requirement has been like 3 months for the bare metal and 1 year for the drug-eluting stents. But depending on, like Dr. Sibas is very correctly said, patient's clinical profile, that is important to decide duration of the dual antiplatelet. And if the patient is financially poor, like in our social situation, so minimum after 3 months, sometimes, of course, now with generic, other many molecules are now available. The cost of dual antiplatelet with this, this ticagrelor has come down definitely. But initially, in high risk stenting, what we used to do, that we at least give for 3 months and then switch to some Clopidogrel or some other antiplatelet medication. So, Dr. Das, what is your
Yes, sir.
duration, minimum
Yes.
duration of antiplatelet, DAPT, and maximum duration? Or, I mean, how do you manage a patient
Yes,
of
sir.
stenting, post-stenting, with a, and what kind of antiplatelet medication and how long?
So looks at there are numerous dichotomous study reports are there. Some study report show that you can go for prolonged duration of DAPT, including a highly potent P2A12 inhibitor like ticagrelor, like DAPT study and your Pegasus study. In all those conditions, the primary composite endpoint like target vessel revascularization, non-fatal MI, and stroke were reduced, but at the cost of bleeding. That is an important part because nowadays you are using thin struts, second and third generation stents. Those are thin struts and they have biodegradable polymer. So those kind of stents that generally endothelialize minimum 3 to 6 months, within 3 to 6 months time. So once you give once you do in the right moment revascularization for the patient, and nowadays the patient's livelihood is increasing or the patient's lifespan is increasing. That means we'll get all these patients of elderly patient, and once a patient ages, the bleeding risk also increases. Once the patient means age increases, the risk of atrial fibrillation also increases, which will also require an oral anticoagulant. So you may have to give a dual and a triple therapy in such kind of elderly patients. So in those cases, the bleeding will be an important part. Maybe you, with these thin struts, you may not compromise on the ischemic or thrombotic issues, but you have to give a large penalty for the bleeding risk. So very much important is that, and some studies like Twilight and TICO, they show that if you go for 3 months DAPT followed by monotherapy with a P2A12 inhibitor, that also reduces your bleeding risk without compromising the ischemia. So I think, and the TICO trial or Twilight trial, these trials were done on not more than 4,000 or 5,000 patients, but Pegasus was done on 20,000 patients. So I think some will go for a prolonged duration of DAPT, some will go for shorter duration of DAPT. It all depends on the clinical criteria of the patient, not merely the presence of stents or a bifurcation lesion or a left main lesion. It also depends on the lipid parameters, recurrent hospitalization for MI, patient smoking status, use of PCSK9 inhibitors, and use of high intensity statins. They also go a long way in reducing the CV events. So it is not a one size fits all regarding antiplatelets. We have to tailor-make each patient, and we have to really see whether the ischemia is an issue, whether the bleeding issue is an issue. Because in Pegasus trial and other trial, they included the patient who tolerated the DAPT well for the first 12 months. And if the patient didn't have any adverse bleeding events, then they continue. And in those cases, the primary composite endpoint was reduced, but bleeding is a still issue. And elderly patient, you may lose the patient to non-CV events due to a massive ICH. So you have to be very, very careful while choosing. And there is, till now, there is no guideline which gives a correct reply up to what duration of antiplatelet has to be given. So it all depends on the local practice, local availability of the drug, cost effectiveness of the drug, affordability of the patient, together with additional coexisting risk factor that is present with the patient. So it will go a long way till we get a real reply to the patient. Nowadays, people are coming with 1 month DAPT and then monotherapy. So till the guidelines come, we have to go as per the recent or the current guidelines what we are using for DAPT of 12 months. If there is a bleeding risk in an ACS scenario, you have to give it for 12 months. If there is a high bleeding risk, we can still curtail it to 3 to 6 months. Whereas in a BMS or in a chronic stable disease, where you use a BMS or DS or a drug-eluting balloon, you can go for 6 months at least of DAPT. If the bleeding risk is not high, if the ischemic risk is high, if the bleeding risk is high, you can curtail it to 1 month.
Good. Yeah, I agree. All patients don't fit into one size. Regarding bare metal, I don't see them anymore in my.
We don't use anymore.
Recently, I looked for a bare metal for a 4 millimeter. Our technician said, "Sir, we'll find out. Let us see like that." So after the cost of drug-eluting stent has come down, so I think now bare metal has become disappeared.
Yeah, bare metal generally we use if I think, sir, bare metal we use in particular scenario in which a patient is planned for a urgent or a emergent surgery, like a patient is waiting for renal transplant, and prior transplant angiogram you are finding a single vessel disease, and the patient cannot wait for 6 months. So in that case, we can use a bare metal stent, at least 1 month DAPT we can give, and we can take the patient for a transplant maybe after 1 or 2 months.
Okay, so we have less time. I think we have another topic before I think we close this topic. One more round of discussion we can have regarding this COVID time. So like recently I had a case of acute MI post-COVID. It was a huge thrombotic burden and patient was also having atrial fibrillation. So I'd ask the panelists, Dr. Sibasis, if you have such a patient, what will be your approach post-COVID, large thrombus load with atrial fibrillation? What will be the antiplatelet plan for you?
So this is another topic of discussion. This is a triple therapy. So with a not only the post-COVID status, a patient with the atrial fibrillation, with a ST elevated MI, who are going for a revascularization, then what should be the choice of therapy? Again, the clear guidelines is that we have to add a anticoagulation. Now with I think the Atlas trial, the rivaroxaban is being added as a acute coronary syndrome in the patient of acute coronary syndrome also, 2.5 mg, that is the dose. So then we have to actually certain the dual antiplatelet therapy, and the patient has to be on a newer generation, the third generation drug-eluting stent, so that we have a shorter duration of antiplatelet therapy, and then we have to add single antiplatelet with another anticoagulation. That is the protocol what is been given, and most of the school of thought is going towards that patient with the atrial fibrillation should have one antiplatelet and one anticoagulant, and to minimize the risk of bleeding. That is the situation. And now you have to, with a post-COVID status also, and with the rivaroxaban that is firmly established is it is beneficial role in acute coronary syndrome. then we can add a aspirin or any clopidogrel. That is actually the controversy. I don't know the answer. What should be the antiplatelet? Whether it should be the aspirin or a single aspirin or a single antiplatelet clopidogrel with rivaroxaban. That is my thought is that we should add a rivaroxaban is a good choice of
Yes,
anticoagulation.
I also did same. I actually gave with DAPT 1 month of 2.5 mg rivaroxaban
Yeah.
with a tight watch on any prothrombotic events, post-vaccine or post-COVID. This patient was actually post-COVID. And the patient is doing well. So
Yes.
there are different evolving situations. So we have to face that. Anyway, thank you. And we can go to the second topic. Can you introduce the second topic?
I think, sir, I will add one thing, sir.
Yeah, please.
In the previous case, in your case, like our co-panelist told that he is confused whether he wants to give aspirin with rivaroxaban or any P2Y12 with rivaroxaban. After 1 month of triple therapy, the guidelines tells that the bleeding risk is increased if you continue aspirin. So if you want to withdraw any drug first, it has to be aspirin. So no point in continuing with aspirin. So you have to give a P2Y12 inhibitor, preferably clopidogrel along with the rivaroxaban, to reduce the risk of bleeding in a case of atrial fibrillation with a stent.
Can you go to the second topic?
Sure, sir. So
Yeah,
the
please
second case.
And I'll add one point.
Please.
Yes.
Regarding this case, last case, this is ST elevation MI, infraval MI, 72-year-old. So regarding, I will just take 2 minutes and all.
Can you
So when you
introduce
start,
yourself?
when you say that aspirin clopidogrel, I'm
Hello?
Dr. Suryakant Jana. Hello,
Yeah,
am I
yeah.
audible, sir?
Yes, yes. Introduce yourself.
I'm Dr. Suryakant Jana, sir. I'm Dr. Suryakant Jana, sir. I'm working in
Okay.
KIMS Hospital.
Okay,
I just
please.
moved in Nurisa for last year. So if you look
Okay.
at this case, 72-year-old male patient, maybe smoker and all, ST elevation MI and all. So when this type of patients come for primary and or billing for primary, you have two options left. Either you load with aspirin clopidogrel 600 milligram or with aspirin and ticagrelor. Without knowing the anatomy, it's actually you can't load him prasugrel. Plus, if you have the extra knowledge of like whether the patient had history of TIA, previous ischemic stroke or hemorrhagic stroke, or if the age is more than 75 or the weight is less than 60 kg, then also it's difficult to add prasugrel because there the dose comes down to 5 milligram. So either you add this patient ticagrelor, if preferably you want to preload him, or you can go with aspirin plus clopidogrel 600 milligram. I think that's the choice. Prasugrel without knowing the coronary anatomy, without having an angiogram, it's not prudent because you might not be sure about the anatomy. It may land up in triple vessel. You may just do POBA or you may just thrombosuck and leave it for CABG, other things and all. Then regarding the duration of antiplatelet therapy, sir, ACS, unless until the bleeding risk is high, it's at least for 1 year. All the studies show at least 1 year. Any acute coronary event patient has to receive DAPT at least for 1 year. Similarly, if it is just a chronic coronary syndrome, DAPT at least for 6 months. Then depending on the bleeding and the ischemic risk, or if patient has some other thing like going for surgery, other things and all, then you may taper or course off for other things and all. But ACS per se, whether you manage medically or stent, if there is no contraindication or bleeding risk, ischemic risk, whatever other things are not there, DAPT is must at least for 1 year. Chronic coronary syndrome, at least 6 months you have to give. Twilight study, what all is like they have compared and all, but if you look at the fallacy of the Twilight study, the major problem was after 3 months they have switched on to only ticagrelor. But the problem is those patients were actually at very low risk of ischemic events. That means now if you are doing a complicated case, which is anatomically complicated, like left main bifurcation, CTO, single patent artery, or you are stenting, total stent length is at least 60 mm. There you can't leave the patient only on ticagrelor. You to give DAPT because unless the risk of bleeding is high. So ACS DAPT has to be 1 year. Chronic coronary syndrome, it's okay 6 months. That's what the guideline says till now. Regarding COVID patient, what you said is the guideline. Yeah, regarding COVID patient or any patient requiring thrombotic, that means triple therapy. Now the guidelines, if you go with the European Society of Guidelines, non-escalation MI, you can actually give triple therapy up till 1 week only. That means aspirin clopidogrel with the NOACs, preferably if you can, that scores over the VK, vitamin K antagonist acetomarin. So if you want to give, you can actually give it just till 1 week. After 1 week, they say you have to go to the dual antithrombotic therapy. That means one antiplatelet and one of the NOACs. And one antiplatelet till now, the data trial, whatever we have is with the clopidogrel only. That means clopidogrel with one of the NOACs if you want to continue after 1 week. Unless until you feel the risk of, it was a complicated PCI where you need to give the dual antiplatelet therapy. There you can go to 1 month. Otherwise, you can give even bare minimum is just 1 week. If you want, if you think that, okay, it was a like complicated PCI, you want to like trade off between the risk of bleeding, ischemia and all, then you can give clopidogrel or ticagrelor with one of the NOACs, but it's class 2B indication. We don't have much data on that.
Okay, so go to the next topic. So, Mr. Omkar,
Yes,
can
sir.
we
Yes, sir. Yes,
proceed
sir.
with the next topic and introduction of the panelists?
Yes, sir. So next topic is on dabigatran in non-valvular atrial fibrillation in newly diagnosed patients. So the case is a 55-year-old female presented in OPD with history of palpitations 2 days back, which lasted for approximately 15 minutes, and similar episodes she experienced 3 months back. If you look at the past medical history, she had a history of hypertension and is on telmisartan 40 milligram, but not taking regularly. Not a history of diabetes, no history of CVD, and no history of any major surgery. The patient belongs to upper middle class family with a vegetarian dietary habits, and she is not on antiplatelets or anticoagulants. Her CBC is normal. Her renal hepatic functions are also normal. Her thyroid functions are also normal. Her ECG at rest is also at normal. Her 2D echo shows that normal valves and chambers, good left ventricular contractility with ejection fraction of 55%, no clots, vegetations, and pericardial effusions. The clinical examination is also normal with BP reading of 122 by 84 millimeter of mercury and pulse is 78 beats per minute. The patient was advised 24 hours Holter monitoring. Holter report showed short run of atrial fibrillation of approximately 10 minutes. So with this, I request Rajkumar sir to introduce the other panelists also. Once again, Rajkumar sir, please.
To have a discussion on this case study, we have with us Dr. Priyabata Sahu, who is at Apollo Hospital, and Dr. Suryakant Jena, who is at KIMS Hospital. Both are DM cardiologists. So welcome you both, sir, for this for your points on this case study, sir.
Yes, sir. Shall I go back to the case?
Yeah, please go back.
Yeah. Okay, sir.
So this is what I gather from the case is a case of non-valvular AF, intermittent AF, because when the ECG was done on the baseline, it was normal. So, intermittent AF, whether permanent AF or intermittent AF, both have higher stroke risk, up to 5 to 7% per year, burden on the patient. And it increases with increasing complexity of the patient profile. The stroke risk will increase if the patient is having other other comorbidities and other factors like adverse score and other things. So newer oral anticoagulants have been now firmly approved. 4 of them, dabigatran, apixaban, endoxaban, and this thing, all are FDA approved. At least 2 or 3 of them are available in India also. Advantage of newer anticoagulation is that they have a wider therapeutic window and they don't need much of the dietary restriction on the patient, unlike the typical oral anticoagulation which used to warfarin and acetylcholine. Secondly, there is no need for drug dose monitoring, that we don't have to monitor PTINR often. So because of this, the reducing cost. So now novel oral anticoagulants are becoming commoner. So in this type of patient, several questions arise that so which anticoagulant NOAC to be started and at what dose and how to monitor this patient. So I'll start with the first panelist, Dr. Priyabrat Das, is he present?
Yes, sir, I'm present.
Yeah, welcome. So Dr.
Uh,
Priyabrat and Dr. Jenna. So each of you first give your introductory opinion, whether to start anticoagulation, if you start, how long to start, and how to monitor the patient.
Sir, so we are dealing with a case of non-valvular AF, paroxysmal AF, but that doesn't degrade the point that the chances of stroke will be less. The lady's CHAD score as 2 with a low bleeding risk with Haspelet score of 1. So the patient is having nearly a chance of 16% stroke per year. So we have to counsel the patient regarding the use of NOACs to prevent stroke. That has to be properly counseled about that. As the patient is belonging to a upper middle class family with so he can afford NOACs, definitely. He has a vegetarian diet habit, so preferably no to oral anticoagulant vitamin K antagonists. And so we'll be starting with NOACs is the various studies those has been conducted. They've clearly mentioned that most of the NOACs are non-inferior, but sub-studies have found that both apixaban and your dabigatran 150 milligram twice daily have been found to be quite superior to the NOACs, to the warfarin. So for me, I would like to start with dabigatran 150 milligram twice daily, and it will be continued till probably lifelong therapy will be given. Is because with increasing age, the chances of atrial fibrillation and stroke also increase. And if not, also the chances of, because even if any bleeding incidents happens, we have an antidote to idarucizumab, which can be used to revert the anticoagulant effect of dabigatran. So I would prefer to go with dabigatran 150 milligram twice daily.
And how will you monitor? Will you not modify the dose if suppose the creatinine clearance comes down? You have given for 6 months. After that, you do a renal function.
Yes, okay, sir.
I mean, 150 milligram is a dose for a normal person. I mean, sorry, yes, I mean this.
Her renal and hepatic parameters are all normal now. So
but overall, you have to monitor the patient. Creatinine clearance is important predictor of how this anticoagulant dose.
Definitely, sir. Once if we find that the creatinine clearance is getting down, so we can reduce the dose subsequently to 110 or 75 milligram twice daily. That can be done.
Yeah. Okay. So, and if the patient in the next hold, do you do Holter repeatedly to check whether atrial fibrillation is happening again and again, or you just continue with the medicines? Or say after 6 months, the patient is not having any symptom. Holter is. Do you advise Holter?
No, sir. As of the chances of once the patient has AF, and the substrate will be that he will be more likely to have subsequent events of AF. So I don't think there is much point in repeating Holter frequently, even if the chances of her getting symptomatic are less, but still the chances of her getting into AF and leading to stroke are still high. So I will prefer to continue with the NOACs.
Okay, fair. So, Dr. Suryakant Jena, your opening. What will you think? How long you will give? How to monitor the patient? What will be your ideal NOSC? Your opinion on this? Hello, Dr. Suryakant Jena is there?
Yes, sir. Can you hear me, sir?
Okay. Yeah, we can hear. Yeah. Well,
good evening, sir. Thanks
opinion
for
on the case.
Yeah. So,
how will you monitor the patient? What will be the dose of which anticoagulant at what dose, and how long you will give?
Yeah. So looking at the case, basically 50-year-old female, and she has just history of hypertension on and off on irregular medications with no other comorbidities, and there is no risk of bleeding as of whatever the history shows. Currently, renal hepatic parameters are not on treatment, and she had history of palpitation 2 days back, and then she experienced a similar episode. It's written almost 3 months back. So basically, if we look at and we found that patient um, had this history, I mean, of palpitation, we have to do a holter and document what exactly is going on. So if we find that she's on this having arterial fibrillation, then she becomes a candidate for antithrombotic therapy, because female more than equal to 2, that means if we remove the gender scoring, even if and it comes out to be arterial fibrillation, then she has to be on NOAC. There is no doubt about that. Why? Because patient, irrespective of whether they remain in sinus rhythm, even if we convert them back to sinus rhythm, they will still be at risk of arterial fibrillation. And the arterial fibrillation increases the risk of stroke almost by 5-fold. And if you look at the stroke by arterial fibrillation are likely to be more fatal. That means the risk of mortality even at 1 year almost comes to 30%. And in persons more than 40-year-old, the lifetime risk of having arterial fibrillation and stroke comes to almost 25 to 30%, even if at this point of time patient is not having any arterial fibrillation. So already female patient with a history of hypertension and then already having palpitation. So first thing is we have to do a holter and document what exactly is the rhythm, whether it is just a VPC or some irregular feelings he is having, or if it is a documented arterial fibrillation. If it is a documented arterial fibrillation, we have to put her on the NOAC therapy. Now coming to this scenario, what among the NOAC, like as you said, we have Pixaban, Rivaroxaban, and the dabigatran. Endoxaban is not available in India. So if this patient at present, if you look at the scenario, she doesn't have stroke. That means if she has not suffered attack of stroke, then what choice we have? We have his dabigatran with us, we have Rivaroxaban with us, as well as we have Pixaban with us. Now, as you said, NOACs more or less, they have similar profile. Of course, in terms of stroke, if you look at the Raleigh trial which we had, or the ROCAT AF or the Aristotle, patient who had stroke, their dabigatran scores better. That means it is more helpful in preventing the risk of stroke. Because Raleigh trial was conducted, I think, around some 15,000 patients. 150 milligram was superior to warfarin. 110 milligram was equivalent to warfarin with same risk of bleeding. Though 150 milligram has slightly higher risk of bleeding, it is more of the gastric side effects. Patient having dyspepsia because dabigatran has that tartaric acid in it because it required low pH for absorption. That was the cause and all. On the other hand, if you look at the so basically 110 milligram was non-inferior, 150 milligram was superior. If you look at the Apixaban, it was non-inferior, and Apixaban, on the contrary, reduced the risk of hemorrhagic stroke more as compared to ischemic stroke. It didn't actually reduce the risk of ischemic stroke more. Rivaroxaban, on the other hand, reduced the risk of stroke, though had slightly major bleeding, but it was non-inferior. So looking at the data, patient having stroke, of course, dabigatran 150 milligram is more favorable. If you look at a little bit of side effect, what exactly we have done, those showed little higher risk of MI in that trial. Apixaban had less risk of MI. And then according to Chadwell score, though Rivaroxaban trial, it was more of, because the Chadwell score, I mean the patient population in Rivaroxaban trial actually had higher Chadwell score. It was around some 3.5, whereas the other trials have around some 2.1 and all. So if you look at this patient scenario without having stroke, I don't mind you using Rivaroxaban or dabigatran or Apixaban. Of course, on the long run, as you said, dabigatran less than 30 milligram. If you are thinking that she may land up in CKD, then you may use either Rivaroxaban or Apixaban, because Apixaban in that point scores better. You can use up till 15 milligram ml per minute. rivaroxaban has the upper hand in terms of single daily dosing. The patient can take single daily dose, of course, with a little bit of dose modification and all. So no stroke, I think anything is fine as long as patient needs single dose or whatever, if there's no sequel. Yeah, but if it's stroke patient and all, then obviously I would think of dabigatran 150 milligram BD as the favorable choice. I would like to know your opinion.
Yes, good. I mean, all your points made are very valid and important in our day-to-day practice. More important, I think, is be comfortable with only one or two molecules and monitor the patient well, because that is very important. We are giving a relatively new medicine, even though it's not very new. So monitoring renal parameter, any bleeding issues, that will allay the fear of the patient so that compliance will be better. The patient will take longer. Otherwise, slight nasal bleed and dental bleed, the local physician will make him terrified, and the girl, I mean the female in this case. So if you have a good monitoring and having only focus on one or two molecules which you know well, so and also one or two brands.
Sir, if you don't mind,
I believe there is.
Your voice is echoing, sir.
Sorry, I know that was the beginning. It was there. Now is it okay?
It is okay now, sir.
Okay, so
yeah,
when it is not occurring on your side, it is occurring on my side. Okay, so like I said, important to monitor and know your molecule. And I believe there is some difference in the brand also. There are so many brands, we have to follow them regularly. So now we have a time for one more round of question. So let us say a patient is already on warfarin and wants to switch to NOAC, any of the NOACs, dabigatran or rivaroxaban, because of the ease of use, and he's staying in a peripheral place where PTINR is not possible. So what will be your strategy, and how will you go? Dr. Priyabrata and then Dr. Jena. If the patient wants to switch to warfarin or acetylene.
Patient.
Sorry. If the patient is already on warfarin or acetylene, she wants to switch to NOAC because the ease of use and whatever. So how do you switch it?
Okay. If the patient is on vitamin C antagonist, acetylene or warfarin, then if the PTINR values are within less than 2, then you can change directly to whichever NOACs is preferable. But if not, we can wait till the vitamin, till the INR reduces, then we can start with the doses.
Yeah, excellent. Actually, one more point I want to make just before Dr. Jena says. Many physicians think that ecosprin is a easier substitute for warfarin, acetylene, or NOACs, which is very wrong, because if you see the trials, the NOACs itself has 18 to 20% advantage over warfarin, which itself has advantage over ecosprin. So it is always better to discourage such clinical practice that using ecosprin or clopidogrel as a substitute for these clinical situations like non-valvular AF or any type of such situation.
Definitely.
So Dr. Jena, please.
Yeah, correctly, Dr. Priyabrata said that once patient is on acetylene or warfarin, you can, hold on it and repeat INR maybe every 48 hours till INR drops down to 2. And then you can switch over to NOACs, whatever you are preferable. And as you said, sir, though previous study and all, when we had this aspirin and warfarin studies, so like your warfarin reduces the relative risk of stroke reduction almost like 60 to 70%. aspirin, I believe it comes around some 10 to 20%, though it reduces the risk of stroke. But currently, if you look at arterial fibrillation causing stroke, that means when we are talking about stroke prevention in arterial fibrillation, the pathophysiology is completely different. It's more like the clot going, unlikely to be platelet and all. So that's the reason this Chad-West score of refined Chad-West score of came, considering gender and non-gender thing and all. So currently we should rather educate the physicians, I mean, who say that, okay, like people will be coming who are unable to do INR, or it's not reliable. Actually doing INR availability is just not the thing, because a lot of time we see that people actually do INR and you would see a report, it's 8. When you do it here in lab and all, you find out it's actually subtherapeutic. On the contrary, you may see it is subtherapeutic, but they will be going on increasing, and then you suddenly realize it is 8 and 9. So doing it reliably is also one of the most important things, because warfarin or aceclopidogrel group of drugs, they have very narrow therapeutic index. The moment it goes little, it becomes catastrophic. If it is below therapeutic range, doesn't work out. It's like not having the drugs. So that's the reason, even in all the trials, it is emphasized that whenever you compare warfarin, the INR has to be maintained at least in the therapeutic range more than 70% of time. Whereas actually, if you look at this Relay trial, Aristo trial, or the Rocket AF, there is a lot of discrepancy. Even the rivaroxaban trial, only 57% of the patients were in therapeutic range. I mean, 57% times, that means. And even the Aristotle Relay trial, 64. So even they could not achieve the 70% of the therapeutic range. The time duration for the therapeutic range. So currently, according to guidelines, aspirin in patients of AF for stroke prevention is not at all recommended. You want to give, you give antithrombotic therapy, or you better don't give. No point in just giving aspirin because it's not recommended.
Absolutely, very true. So if you have any take-home message, that atrial fibrillation should be taken seriously. It's a major cause of morbidity and mortality.
Yeah, obviously, as I said, sir, almost 5-fold risk of stroke, and then stroke because of arterial fibrillation is much more catastrophic, because you will have showers of emboli, and then there are multiple things. And one important thing, as you said, these patients of arterial fibrillation should actually, even if you treat a patient of AF, you have reverted him to sinus rhythm, in between you should always go on asking whether you still feel that palpitation or you have this AF, because sometimes if it is a very low rate on beta blocker, 50-60, and you clinically palpate, you may actually feel that. And if you're not following the ECG or Holter, then you may actually feel that patient might be in sinus rhythm. So why it is important? Because on a long run, when AF persistently continues, or it becomes long-standing or persistent, it actually leads to LV dysfunction also. So synchronous activity between the atria and the ventricle is most important. So if patient is willing, or it is not a permanent AF in the sense, when we or the patient accepts that, okay, we no more want to go for the rhythm conversion strategy, then you may leave it. Otherwise, it's advisable to convert the patient to sinus rhythm if possible, whenever, so that we don't once LA enlarges, their velocity of the appendage reduces, there is likelihood that even if patient on anticoagulation, still, though you are reducing the risk of stroke and clot, but still there will be clot. So it's always better to have sinus rhythm than having arrhythmia and with anticoagulation. So you should always follow up, treat these patients aggressively, and then
So basically, AF has two major things. One is rate and rhythm. Another is anticoagulation. So our topics today is mostly focused on anticoagulation, being a first topic. So basic take-home message is that AF should be taken seriously. It is a very important cause of morbidity, and don't settle for ecosprin, clopidogrel, other things, hoping that it will work, because it's always NOACs or at least acetrom or any traditional medicine is better. If your patient is having definitely atrial fibrillation. So
sir, I want to add, sir. I want to add something, sir.
Yeah,
sir, I want to.
Yeah,
yes,
last
sir.
comment.
Any patient who is also having atrial fibrillation, those who cannot afford a NOAC, then in this condition, if they are on warfarin or acetron, it is very much important that suppose their INR, suppose they have 5 or 6 INRs, and at least we have to see that 60% of time they are in time in therapeutic range, that is called TTR. So if their INR is more than 60% of times is above therapeutic range, I think they can continue with warfarin. Otherwise, they have to be switched over to NOACs. And another thing I want to point out that many of our cardiologist friends also, whenever they start a NOAC, they have a physician inertia. Like they do not start a elderly patient of 65 years who has been diagnosed with atrial fibrillation. They will underdose it to like dabigatran 110 or 75, thinking that it is going to bleed. But whatever the trial has shown, that you have to give the maximum dose to reap the maximum benefit without having to think about bleeding. Because the trials which have been conducted, like Rely Rocket or Aristotle or TME48 for edoxaban, all have consisting of more than 70,000 population. And in all those trials, they have been compared head-on with warfarin, and they have found that the bleeding risk is less than warfarin. So there is no point in underdosing NOACs. So to reap the maximum therapeutic benefit, it has to be given in a maximum dose, unless and until the GFR is less, where you have to do a renal modification of the dose.
Okay, Dr. Pradeep, well said. Good. And thank you for this nice, interesting discussion. Mr. Omkar, can you give closing statements?
Yeah, again, good evening, sir. Myself, Rajkumar Rawat. So before we close this session, we have one more thing which is added right now with us. It is the Connect to Clinic, which is a online platform which Alchem is giving, sir, for online consultation. And I think you all would be knowing about this platform, because last year we have introduced this platform in the Indian market. And now we have added various features in this platform, like instant consultation. Doctor can initiate instant consultation with patient without need of booking the time slot, because nowadays maximum patients are doing teleconsultation and through WhatsApp calling they are doing. So in this C2C also we have added this. Then three-way AV consultation we have added. A patient can add one caregiver also along with the patient in online consultation. Then physical consultation also we are adding. Even you can do physical consultation with this C2C. Then doctor can add his staff also, who can take care of patient booking or everything. And then we have added some more features like without having OTP, doctor can log in with the password. Then you can patient upload with any other old platform. You can upload all your old patient to in this C2C also. And after adding one more thing which we have added is adding vacation days, because you can add vacation days in calendar also, so that in those days patient cannot book the appointment. And also appointment booking period we have extended to 90 days. So up to 90 days patient can pre-book the appointment of a consultant. So these are the new features which we have added in our C2C platform, sir. And with this, I take this opportunity to thank Dr. Lingaraj Nath for moderating the panel discussion and ensuring the audience are engaged with clinically relevant messages. We also thank all the panelists who are with us in today's webinar: Dr. Pradeep Kumar Das, Dr. Suryakant Jaina, Dr. Priyavata Sahu, Dr. Subhasis Misra. And we also thank all the doctors who have joined us for this panel discussion. Dr. We at Alchem Laboratories will continue to serve doctors and patients by making our products available, especially our Dabiclot and Tikavik. So thank you, doctor, once again for giving us time and sharing your views. Thank you, sir, and good night.
Thank you.
Thank you.
Thank you very much, sir.
Kind of the